I'm going to talk about craniofacial surgery in general. So, craniofacial reconstruction, the timing can be as early as newborns, like when we do neonatal distraction, or it could be as late as way after skeletal maturity, as in this 40-year-old patient with monoblock distractions. So, why would you ever operate on a newborn doing a complex craniofacial case? Well, when you see um, the parents see this child retracting and struggling to breathe, and you have to offer them something, then you may opt for something to avoid a tracheostomy. So we had a patient here, next gen face patient at Lenox Hill, who was diagnosed prenatally with micronathia, also had genetic abnormality, which was picked up by amniocentesis, was delivered full term here at spontaneous vaginal delivery at Lenox Hill Hospital, but had immediate airway difficulties, which was more of a surprise to us. Failed nasal pharyngeal tube and could not be intubated. We had to use an LMA and then make a plan for the next morning. But before I get into that, so paraband sequence is not a syndrome. It has to do with the mandible being small, the tongue having nowhere to go, so it goes to the back of the throat and does not allow the palate to develop normally. So in this case, we had a situation where there was airway obstruction, but also paraband sequence is considered, there's three different kinds. This was paraband sequence plus because of the comorbidities with genetic problems. There's also syndromic or just plain paraband sequence, which most of the time can be managed expectantly. So when we see these patients in the NICU, we look at an algorithm to decide, do we distract or do we not distract? So if they have moderate to severe obstruction, we do certain tests like a sleep study, reflux study, and direct laryngoscopy. If they have obstructive sleep apnea from the tongue base and there's no other airway lesion, then we consider mandible distraction as opposed to doing a tracheostomy. So that's what we did in this situation. 16 hours later after birth, went to the operating room, did a airway evaluation and intubation, which can be very challenging. You can see the gingival difference was 13 millimeters, so we opted to do a distraction, which we typically do with a Risdon incision, inverted L osteotomy. We use internal devices. They're less cumbersome. We bring out the arm posterior behind the ear, and we distract 2 millimeters a day. You can see in the OR, this you check the distractors. That's the plates separating, the bone separating in the middle there, so we know that it will work. And then you can see the pre on the left, post on the right. The difference of that arrow is the new bone that will form. So after the finished the turning and finished repositioning, we removed the turning arms at the bedside. In this case, we had improved chin position, no desaturations, and typically once patients are feeding well, we can send them home and then they go home more normally, where they can get their cleft palate then repaired if they have that at around 10 to 12 months of age. So, why do it this early? Well, if the parents can bring home a baby without a tracheostomy, without monitors that are going off and alarms, then it improves the parent-baby bonding. And so there's certain benefits that we don't study, but we know are there after this procedure. The other extreme, sometimes we do older patients. Now, this patient had multiple procedures, but still had a lot of eye exposure pain. She had to wear 24/7 contacts to cover her eyes because it was in such pain. And she also had some obstructive sleep apnea, class 3 malocclusion, despite her previous procedures. So we have to weigh, is it worth doing another procedure or not? In this case, because of her concerns, we opted for a monoblock distraction. And this is a schematic of what the monoblock acute advancement would be like, which was an option in the past. However, it can be a risky procedure because when you advance both Lefort 3 face and the forehead, you're communicating the nose with the subdural space, the nose which is bacteria, subdural space which is sterile, and that can lead to infections like meningitis or abscess. So now we proved that we can do this safely with distraction. So we do the same bone cuts, we leave things intact for mucosal healing, and then gradually bring it forward. And this will correct the obstructive sleep apnea, help with eye exposure problems, and even fix the occlusion in some cases. So this is the patient, same patient. So we wanted to help with her eye exposure problems, correct that, and even though that was her main concern, but it did help with her obstructive sleep apnea, and we're working with the team orthodontically with her occlusion. So again, infant procedures. So common procedure has to do with craniosynostosis. The sagittal synostosis, as seen here with that fused suture, it should be a suture there. What happens is you get elongation in the AP dimension and biparietal restriction because the growth, the suture cannot expand. So there's different modes of treatment. You can do endoscopic strip with a helmet. You can do springs. You can do a reverse pie procedure or a total cranial vault. So the reverse pie procedure is kind of in between them. You're treating the pathology, and that's my preference, although others are effective also. This is a schematic of that. So you can see this schematic where the suture is being removed, then barrel staving, particularly removing the parietal bone, and then you can see actually Dr. Calmodi used to really bring the AP diameter to narrow that so we could expand in the biparietal width, and it's kind of scary when you first see it, but it's effective in treating the head shape. And you can see this sagittal synostosis, you get bossing in the front, which corrects itself, even though you're just dealing with the pathology in the middle. So that's sagittal synostosis. What about if you have coronal synostosis bilaterally? So again, you have to treat this surgically. Options: endoscopic strip and a helmet, or frontal orbital advancement, or distraction of this. So the traditional frontal orbital advancement is very effective. These patients, you can see, have a short forehead, which is brachycephaly, but also have a tall forehead, which you can see on a different view. Frontal orbital advancement is always effective. This is a schematic of how that happens. So to advance the forehead, to advance the supraorbital brow, to create space, as well as to lower the head so you don't have that torocephaly. So Dr. K used to teach the residents, you want to overcorrect these cases, and you want to be able to keep the eyes dry when raining. That's what he means by overcorrection, because it will come back, and you can see how it comes back and they can look normal, but overcorrection is important in these patients. So bilateral coronal synostosis can happen with craniofacial dysostosis. You can see all these different syndromes have tori brachycephaly, but they also have mid-face hypoplasia. They can be seen with proptosis, shallow orbits, but these are the cases you'll see the coronal synostosis. In these cases, you have to reassess to see if they need posterior expansion. We used to do that around a year of age. You can see the kind of shaping with barrel staving, using a plate to secure that, reducing the height again, and recontouring the orbit. So more recently, that protocol has been changed to do an earlier posterior vault distraction. So there are some advantages of this because it can be done earlier. You can leave the bone attached so it's less bloody. You leave it attached to the dura, and then if you get enough correction, you don't have to address the front part. You can delay the monoblock and operate in pristine tissue later on in life. So this posterior distraction has kind of changed our protocol, I would say, in the last 10 years to deal with craniofacial dysostosis patients. So this patient, Curzon syndrome, localized on the face, she had her advancement, and now you can see her mid-face around the eyes need to be advanced. We did a Lefort 3 distraction to correct that, to improve that. So she had her forehead done when she was a baby, and then at mid-childhood, she was able to have her mid-face advanced. Going back to other synostosis, so unilateral coronal, you can see that with that suture fused, you get oblique head shape, plagiocephaly, plagio meaning oblique head shape. So it can be endoscopic strip and helmet, frontal orbital advancement, or distraction. The frontal orbital advancement will give you correction on the table, so you don't have to worry about the helmet that you're relying on. Now I put this here because VSP has changed how we're doing a lot of procedures. You saw Dr. Hirsch with his reconstructive surgery. We're even doing it for these just to give us more information. On the left is the pre-surgery. On the right, all the colors kind of match up to figure out where all the bone pieces go, and we're able to kind of plan that out. The arrow is where the synostosis is, and you can see on the right the advancement and the change in bone color, change in bone shape that allows us to correct that, allows us to twist the bone appropriately and get all the subtleties. You can see from a worm's eye the advancement that we're doing to correct that. We do a slight over advancement, and then on the table the different colors represent the bone. So we know anteriorly is the nose, posteriorly is the bottom of the screen. We use resorbable plates, which are in there, but it's hard to see. And then we get our results. So you want to overcorrect that side in order to see that correction. So lastly, plagiocephaly, if it's twisted like this, basically no surgery, just helmet remodeling. And I bring this all, the residents have their in-service soon, so it's important to know all these. Metopic synostosis, very narrow temporally, mid-forehead ridge, that's what's causing it. Again, restriction over the suture. So the metopic suture does fuse in normal children, but if it fuses prematurely, that's considered craniosynostosis. This is interesting because you can have mild, moderate, or severe cases. In mild, nothing to do. Severe, operate. Moderate is the gray zone where we have to decide what to do, and that's in conjunction with the parents. There's a subset of these patients that have developmental delay, and it may not be related to what we do in surgery. So again, endoscopic versus open, there's different camps for that. And you can see that was the restriction. The green arrows are the compensatory growth. Every time there's restriction, the brain's normal, so it's going to push on different areas to compensate for that. So that I bring this in here because all these craniosynostotic syndromes will have surgery of the midface and lower down later in life. So you can see all these procedures. So this is after the frontal orbital advancement, the overcorrection. This is after a monoblock, we fix the face at 7 years of age, at 10 years of age, right before Lefort 3 surgery at 12, and then right before his orthognathic surgery, which is at Lefort 1, then afterwards. So multiple surgeries from the top down, depending on the growth of the patient. So some of these patients need multiple surgery throughout their childhood. You can see the lateral changes as well, and you can see what we do from the top, primary surgery, mid-face surgery, and then orthognathic surgery to get our correction. I'm going to go through a few, so this is craniofacial microsomia. For the resident, the Omen classifications remind us that there's ocular orbital involvement, mandible involvement, ear, nerve, soft tissue. So you may have heard this from our previous two lectures, the orbital. So this patient has a facial asymmetry. We did double jaw surgery, but she still had orbital asymmetry. We did a box to her orbit to lift it, to correct that. So she had orbital problems, but she still had flatness on the face. And we did a free flap, which Dr. John Siebert has popularized, which is a parascapular flap. He calls an IMAX flap to fix that. You can do fat grafting serially, but in this case, it was too big of a volume. So in this case, we did do fat grafting. We did distraction from the first picture to the second, and then fat grafting to help with the third. So Dr. Hirsch was talking about mandibular hypoplasia with these cases. You can do distraction in mid-childhood to increase the bone, and you can see the correction, but you got to decide who. So Przanski, class 1, smaller mandible, but still within the fossa. Przanski 2A is out of the fossa, 2B, even smaller, and 3, there's no condyle, there's no ramus. So 3 would need a rib graft unless you can get away with distraction. 2A and 2B may need distraction. For Przanski 3, you can see the rib on the left, the growth of the patient growing further, even overgrowth, so we had to do a setback. So the rib can be unpredictable how it grows. That was one reason I was asking Dr. Hirsch the question of what should we be doing things differently. Dr. Thorne covered ear reconstruction. I'm fortunate to have him as a partner so he can do these because we had to struggle through these when I was out west. You can see all the surgeries that a craniofacial microsomia patient may have with distraction, ear reconstruction, orthognathic surgery. All those are opportunities to add fat so you can avoid the free flap when they're skeletally mature. This is one of our patients we did recently. Obviously, you can see severe facial asymmetries, golden Haar syndrome, which is the most severe form of craniofacial microsomia. I show this again to focus on the virtual planning to recorrect that. You can see how the face has to be twisted and brought over. These are our cutting guides that we use to lengthen the right, shrink the left side. You can see we can see the tooth roots to avoid injuring them. You can see the difference of asymmetry is more three-dimensional, even the mandible, the difference of symmetry, and how we can avoid the nerve, avoid the tooth roots, and really look through the anatomy with this. And you can see this is the correction, the plates we use for the reconstruction. On the right side, we had to use a bone graft, which you'll see in that plate. And this, again, is all how we plan it. So you can see that bone graft on the right going in there from the hip to fill that gap to help with the reconstruction. So again, pre-op to post-op, twisting to improve the sleep apnea, to avoid that, and to have him come to a point where he can begin his orthodontic and final corrective surgeries. Romberg syndrome is progressive regional facial hypoplasia. This is a severe version of it. Usually we may just see soft tissue, but the severe kind you'll see bone. So this is a more mild one. You can see that kind of coupe de sabre, we call it, which is deficiency of soft tissue, and then after fat grafting. More severe cases, you'll see it, that'll affect the face with face scoliosis. We did a double jaw procedure, septorhinoplasty, fat grafting to give her more symmetry. So sometimes it can affect the soft tissue and the bone. In this case, even more severe, again, an IMEX flap for soft tissue like Dr. Siebert taught us, fixing the orbit and then working on the soft tissue. Too much for fat grafting here. Fibrous dysplasia, it's considered a benign craniofacial tumor, but I use that in quotes because it's not truly a tumor, but can act like that one. It's a developmental anomaly. It's basically a somatic mutation of the protein transcript of GNAS1. So basically the bone maturation is arrested at an immature stage, and we get fibroblastic proliferation that replaces the bone. And you can see the zones of fibrous dysplasia. It could be monostotic, which is one bone, or it could be multiple bones, which is more severe. So in this case, we have one bone, the zygomatic maxillary complex is involved, and then we have to decide what to do in this case. So we did a study looking at a limited resection versus bone contouring. The radical resection is not necessary because, again, it's not a true tumor. So we feel that limited resection with grafting had less recurrence and less need for further surgeries, although it's a bigger procedure. And this is what this patient had. She had a ZMC involvement, reconstruction, because she still has a cant here, still has soft tissue ptosis, which had to be corrected later. This patient has left supraorbital involvement. You can see the eye is pulled down and proptotic. And to correct that, we had to work on the frontal bone and the orbit. And this is here after 5 years of correction. You can really see the orbital correction from a worm's eye view. That's why we show this. This is a patient that's come to us that is going to have an upcoming case very similar to those, similar procedure. Once we're going to do virtual planning to help us with this. A couple more syndromes to talk about. Treacher-Collins syndrome, which is a constellation of Tessier 6, 7, and 8 clefts. It's rare, although it's within a family you can see because it's autosomal recessive. It involves the orbits, malar hypoplasia. There's jaw deformity, but it's always bilateral symmetric. That's why patients can look alike. This is one of my favorite reconstructives because you can use both bone and soft tissue to reconstruct this. So full thickness cranial bone grafts as well as can help with the orbit and malar reconstruction. You can see the full thickness graft here on the zygomatic arch and the lateral orbital wall to do the reconstruction, and then the soft tissue with the eyelid switch flap and lateral cantipexy. So all those, it's combining both soft tissue and hard tissue to get a full reconstruction, which we can see around the orbits, around the eyes. You can see transforming from a sad appearance to a more normal looking orbital appearance. So the timing of these procedures is very important because if it's too soon, the bone will just dissolve. But if it's too late, then there's psychosocial implications that children have to deal with. So it's always important to understand the patient and then the pathology. And lastly, we're going to look at a study that we recently did that looked at hypertelorbitism that was corrected by facial bipartition. So Dr. Tessier, Ortiz Monasterio, Van der Meulen first described this facial bipartition to correct orbital hypertelorism. They knew that you could fix this without injury to optic nerve, fixing both craniofacial dysostosis and clefts. But what wasn't looked at was exotropia. So we looked at that, whether that would be corrected as well. You can see from this Tessier cleft, the eyes pointing to the right, And then afterwards, with this facial bipartition, we fixed the eye movement problem. So it happens in some of the cases, we've kind of looked at it more carefully with our 0-14 clefts, exotropia preoperatively, fixed postoperatively, and then this is a case I did with Dr. K as a fellow. Long term, you can see the orbit, the eye movement is fixed, even in follow-up. So we looked at this multiple patients that had moderate to severe hyperteloorbitism, and you can see the craniofacial clefts, the improvements in strabismus, exotropia, and depth. And then our dysostosis patients, improvements in strabismus, exotropia, and depth as well. So for both, exotropia is more common than you would think. There's a new indication for bipartition to fix exotropia, and strabismus muscle alignment should not be done before bipartition. Finally, there's a lot of psychosocial aspects of care that should be looked at with our patients. So this patient lived with this post-traumatic deformity for many years after she was hit by a drunk driver. To understand the pathology, we had to really look at what we had needed to do, including doing a cranial bone graft to her nose, including medial canthal repositioning, so to allow her to live more normal life. Same with this patient with a left ZMC orbital deformity. So initially this was thought not to be fixable, but we realized by stripping the soft tissue, putting it in a new position, we're able to fix the orbit and malar region. So in summary, we have to look at what we're doing craniofacial based on the patient's growth. Dr. Sarnat, who was the basic science person who teased this out, Dr. Tessier, who's considered the grandfather of craniofacial surgery. That was important to both of them. But then we aim to improve our techniques and keep an open mind, always looking at new technology. Dr. Kawamoto, Dr. Cutting sweat the details, which is very important for these procedures. And Shelley always considers psychosocial components of really treat the patient, not just the pathology. And Dr. Thorne, be critical of your results. Always look back at your results and try to improve things. And the Next Gen Face team, to look human is a divine right. So I want to thank our patients, including here Rokas, for allowing us to treat them, allowing us to be able to advance their care and advance craniofacial surgery.